So, what is shared decision making? Well, it's a process where clinicians, so that's us, collaboratively help patients to reach evidence informed and value congruent medical decisions. So, this is where the communication comes in. And as we heard earlier, communication is important not only in vaccines, but in everything we do. And in pregnancy, there's a really complex trade off between potential harms and risks of medical care, potential benefits, because there are two patients involved, the mother and the fetus. And sometimes there are competing interests between the mother and baby when we're making medical decisions. So, where were we before shared decision making? Well, in the past half century, there's been a big shift in the ideal model for making healthcare decisions. So we started out with a more paternalistic model, and this may exist still in many parts of the world, but in the US, we've shifted from this. In the paternalistic model, the physicians really made the medical decisions for patients. And interestingly enough, if there were discussions for pregnant women and their children, it was often the husbands and fathers who had discussions with the physicians and not the patients themselves. I happen to be rereading this book, Death Not Be Not Proud. I don't know if many of you have read this. It's about a young boy who, as a teenager, developed a brain tumor in the 1940s, late 40s. And it's fascinating to me. It's written by his father, who is a reporter. And basically, it's a report of what happened to his son when he was growing up and diagnosed with a brain tumor. He did eventually die. But he just matter-of-factly reports on the discussions made with physicians. And basically, the mother was not in the room, and neither was the patient, who was a 16, 17-year-old. So that would be very different than the discussions we'd have today. Then there was an ethical shift in medicine towards patient autonomy, where patients really get to make the decision, but really they don't have the insider knowledge to make the best decision in many cases. And so now we're in the model of shared decision making. And really, this is a model where we end up in the sweet spot in the middle, where the patients and their families' goals and preferences come together with the research, evidence, and expertise, which is our end of our part of the circle, as well as the biopsychosocial context. So this is really the community and the insurance, system, et cetera. And we have to all come together in the middle to reach a decision that's acceptable to all parties. And this is what the model is envisioned, how it's envisioned by CMS. So in the US, the Center for Medicare and Medicaid Services really determines our insurance payment and drives a lot of what we're doing in healthcare nationally. And they envisioned that eligible beneficiaries, so our patients would be identified, that these patients and families would be given decision aids, which are specific education tools. Then we'd along with us, we'd have a specific meeting or, really a separate visit to discuss decision about a certain treatment or testing, et cetera. And then they would like us to track and report this. And so this model was implemented for several types of specific healthcare, including implantable cardioverter defibrillator replacement in adults. And so the keys here for CMS are these patient decision aids, and then the shared decision-making discussion and documentation in the EMR. The tracking reporting is required for payment for some procedures now in the US. So what about patient decision aids? They are supposed to present the risks and benefits in an easy to understand manner for all our patients. So here's an example of a decision aid from the UK. This was made for patients who went to the ER with chest pain, who were found to have negative workup for MI. So these patients had negative troponins and, and basically ECGs were okay. So they wanted to have the patients decide whether to go forward with an admission to the hospital to do further workup or go home and follow up with their primary care doc. And the data showed that of adults who show up to the ER with chest pain with a negative workup for acute MI, that 3 out of 100 will go on to develop a true MI or ischemic event within 45 days. And so they're not at zero risk of heart disease. But the question was really put to patients, do you want to get admitted for the workup or you just want to do it outpatient treatment? And obviously the driver here in part is going to be payment. So an outpatient treatment is cheaper, but it's actually probably preferable to a lot of patients. And so this is a nice example where the data is presented in a way where pretty much everybody could see this chart and see that they could have a risk of a future MI within 45 days, but probably won't. And then do I really want to go and spend a couple days in the hospital for my workup, or do I want to get an outpatient follow-up? And it actually, this is really a visual way of saying you're in the 3% or 97% of you won't have an MI within 45 days, otherwise known as 1 in 30. And what we've been learning is that most patients don't understand percentages. Even though we talk all the time in percentages in terms of outcomes, people really can't grasp that in their day-to-day lives. And so saying things like 1 in 30 or having a pictograph like this is actually much more effective communication with our patients in many cases. So this would be an example of an effective decision aid. Here's one which I kind of made up that we might want to use for hypoplastic left heart syndrome. So as you know, in the era before 1984, there was no survival for this heart defect. And from a recent review in 2015, the survival in the most recent era has been about 42%. Lower if you're preterm and higher if you're a term birth. As we discussed earlier, risks are higher for preterms. So question is, should we, I know we don't now, but should we hand out something like this pictograph to our patients showing of all comers in the current era who would have survived? So the survivors would be in yellow and the kids who do not survive in purple. And so perhaps we should be leaning towards doing some sort of more visually easy to understand decision aid for our patients when we're having discussions in pregnancy when we diagnose things like hypoplastic left heart syndrome. The other thing that's interesting about this field is that the science of risk taking is fascinating. There's a whole range of people's behaviors when it comes to risk. Some people love the adrenaline rush that you get, the chemical changes that happen when you're taking a risk. Some people are attracted to that, whereas other people are risk aversive. So even within the physicians who are taking care of our patients, we all have our own range of risk tolerance, whether we like it or not, and guiding us, as do our patients. And we're not rational when it comes to taking risk. So for example, after 9/11, a lot of people decided they didn't want to fly because they felt that it was unsafe. Yet we all know that a fear of flying and turning to driving instead of flying is irrational. And so it was documented there were actually more accidents after 9/11 when a lot of people didn't want to fly. Because we weren't rational and we thought we were avoiding risk, but we were actually increasing our risk of an event if we drove. So risk taking is interesting, an interesting topic, and it's not rational, and we don't always make our decisions based on rational data. So What is shared decision making not about? Well, it's not about convincing our patients to follow our recommendations, right? That's sort of probably an older model, or saying we know best, you should do what I say. That's not what it's about. It's not about giving patients whatever they ask for, right? So it's not like ordering off a menu in a restaurant. So we can't just hand them saying, menu saying, well, you could have a BT shunt, or you could have a hybrid procedure, or you could have, um, you know, some other procedure for your congenital heart disease. That's not what it's about. But it really is, and it's also not about letting patients decide on their own, giving them the information and leaving them alone. It's really about talking it out with them and trying to figure out where they lean on the spectrum of risk taking versus playing it safe, et cetera. So we talk about estimating the risks. What about the benefits of something? How do we quantify the value of a fetus versus the mother, of a procedure versus not procedure? Well, it's actually really personal. So we ourselves and our patients will have different opinions about the value of the mom's life versus the fetus, and about whether we lean towards doing, maybe taking a risk up front and doing a procedure, or rolling the dice and deciding to defer risk and seeing what happens, let things happen on their own. And so we really do need to be aware of our own personal biases when we're having shared decision making with our discussions. With our patients, and this can be tough. Other risks that we actually are quite aware of often in medical field are legal risks, right? So what are the legal ramifications of choosing treatments that favor mom or baby? And that could be complex and confusing to caregivers. I know we're always worried, at least OB, and correct me if I'm wrong, but you worry that, down the road, if you make a decision that puts the fetus at risk, that whether there'll be ramifications later on from medical legal standpoint, and perhaps vice versa with the mother too. It can be very complex in pregnancy, the legal field. And so why is data important to shared decision making? Well, we really do need to have our patients reach evidence-informed decisions. And really, the data does take bias away from our personal opinions if we present it in a way that's easy to understand and non-judgmental. And so unfortunately for pregnancy, there's limited data about many of the treatments we can and do provide for mothers and fetuses. For example, most of the drugs we use to treat cardiac arrhythmias in adults have not been well studied in pregnancy, and that's related to my talk earlier today. The other thing we've heard about fetal treatments, many of which are still quite novel, and we've heard about some of those during this conference. We just don't have great data right now in terms of outcomes to present to our patients and their family. And so in the future, if we're going to have ideal shared decision-making in pregnancy, we need more evidence about treatments during pregnancy so we can make better informed decisions, really knowing the safety and risks of diagnostic tests and treatments. We need better decision aids based on this evidence, given that we don't usually have easy to understand handouts for our patients for many of the conditions we treat. And we need better guidelines for the treatment of pregnant women, given the fact that we don't have a lot of randomized controlled trials in pregnancy to date. And so an example of this might be the arrhythmias in pregnancy guidelines that are coming out soon. So thank you very much. Key takeaways are going to be that shared decision-making is the new gold standard in healthcare, that we need to be aware of our own personal bias when we're presenting diagnostic treatment options and treatment options. And we as caregivers tend to favor treatment versus not. And we may have our own personal bias about the value of the fetus versus the mother. Certainly as pediatricians, we highly value the fetus and the baby. And so wherever possible, please use evidence-based decision aids if they're available. and another plug for outcomes research in OB and fetal care going forward. Thanks.